So next up is Dr. Jag Gill, and he's a transplant nephrologist at St. Paul's, and he's the chair of the BC Transplant Data Committee. So welcome, Jag.
Thank you. So good morning or afternoon, everyone. I slept in a bit today. I've been asked to speak on recipient eligibility, which is a bit of a broad topic, and so what I thought is I'd go through this outline a little bit, and really I think the purpose of this is to generate some discussion and generate some questions. Whether they're asked now or at a later time, I think doesn't matter, but the point is to get you thinking about some of the different issues. And so, I thought I'd highlight the benefits of transplantation, which I think are known to everyone in this room, but it's still a good reminder to see exactly what those are, so we have something to tell our patients. A bit of discussion on who does and who doesn't benefit from a transplant, because it's not a uniform benefit for all our patients, but I think it's important to understand the nuances of that. I'll show you some data on the type of patients that we are waitlisting right now and what our wait times currently look like, and then briefly go through what the transplant assessment looks like for patients, and then some very practical issues about when to refer patients and what some of the limitations to the ideal scenario are. So this is US data, but I think it's always a striking slide because it shows what the projected growth of prevalent dialysis and transplant populations are. And so as we all know and we experience every day, end-stage renal diseases continues to be a major issue, and the growth of patients that require some form of renal replacement therapy persists. This is Canadian data, and actually we've had a bit more of a leveling off in terms of end-stage renal disease, but I think that if you look at what's happening in terms of earlier identification of patients with kidney disease at the CKD stage, there certainly has been growth there. So, even though we're having some leveling off, and perhaps some of this is better care at the CKD standpoint, and perhaps some of this is offering patients alternatives, such as conservative care in some scenarios, we're seeing maybe a flattening of ESRD, but we still have a large number of patients that we have to deal with here. These are BC numbers, and I apologize, they only go up to 2012. I couldn't find my updated slide on this, but it highlights the point again that we've seen a growth, and most of this has been in CKD. We've had about a 50% increase in dialysis patients and a 400% increase in CKD patients that are followed in the province right now. So certainly the demand for transplantation is high. This is a slide that kind of quantifies the benefit of transplantation in terms of survival benefit. So if we think about the two major benefits of a transplant, A is quality of life, and B is actual prolongation of life. So unlike some of the other organs, such as a liver or a heart, transplantation is not your life-saving therapy, but it is life-prolonging. And so there is a tangible survival benefit. So I'll just talk you through this because I think it's an important slide. So this here is looking at the relative risk of death among patients that were waitlisted in the United States for a deceased donor transplant. And so this hash line here really is what happens. This is like your baseline risk of death, which is benchmarked at 1, saying basically you've got a standard risk. So this is what happens if you never get a transplant. But as people get a transplant at various time points after transplantation, this is what your risk of dying is in the early period after a transplant compared to if you did not get a transplant, and then long-term at various time points, what your risk of dying is compared to not getting a transplant and staying on that wait list. So early on after the surgery, in the first couple months, obviously there's a spike. There's an increased risk of death after transplantation. But by the time you reach about 100 days, the risk of death is equal among patients who have gotten a transplant and those on the wait list. And then thereafter, the risk of death is lower in transplanted patients. And so this part here and ongoing beyond your 240-day mark, really you've got a survival benefit. And so by getting transplanted, these patients are living longer. And this is really the most, I think, quantifiable benefit that we can offer patients in terms of survival. Now, a lot of studies have been done to try to say, well, this is looking at everybody, but there's obviously every patient is not the same. And so in which subgroups do we continue to see this type of a curve and this type of a benefit? Well, what about elderly patients? And this is often the one that we get asked because ESRD is a high proportion of elderly patients. Well, it depends on who the elderly patient is, quite frankly. And so I'm pretty sure he'd do reasonably well based on his quality, and he's already got a pretty good quality of life, so I think that's important. But if you look at, if you look at actually even, this is looking at 60 to 74-year-olds and looking again at the relative risk of death, what you see is there is a benefit in patients over the age of 60. And I haven't shown you this, but there's been analysis that's looked at people over the age of 70 and people over the age of 80, and it goes on and on and on in terms of if you will see a survival benefit. The important thing here is this is relative to staying on dialysis. So if you have a 75-year-old on dialysis, the risk of dying is quite high. If you transplant them, that risk goes down, but the risk of dying is still not low. And so the question we're always struggling with is, well, how much of a benefit is important and how sustainable is that? So if someone's 85 and they might get a few months more, well, maybe that's not actually such a great idea. But if someone's 78 and you think they're going to live for 5 years and they're actually going to extend that longer with a transplant, well, it's very justifiable to transplant that patient, particularly if you're going to see a quality of life benefit there. So I think it's important to think that elderly patients, selected elderly patients, do have a significant benefit. This is the one I was showing you about survival. This is the exact same curve that I showed you earlier, except this is restricted to patients over 70, and so it does hold true. What about diabetic elderly patients, a more complex subgroup? Well, yes, again, consistently we see a survival benefit in those patients with transplantation. What about obese patients? So this is an analysis looking at that same curve I showed you, stratified by body mass index, and what you see is that even patients with a BMI of over 40, yes, their perioperative risk is very high, not surprisingly, but once they get through that early period, they even have a sustained survival benefit with transplantation. HIV positive patients are another subgroup of patients that traditionally were considered high risk, but again, there has been many reports of successful transplantation and their outcomes are very similar to non-HIV patients post-transplantation. So that begs the question, I've made an argument that everybody can be transplanted. Well, there's obviously some people that we can't transplant. Well, there are some patients here, and so really, I don't have specifics other than the major things. This is really what our assessment entails, trying to identify these patients. And so anyone who we think has a high risk of perioperative death. So for example, as I said, if you have an elderly patient and they have non-revascularizable coronary artery disease or significantly impaired cardiac function, well, they have a very high perioperative risk, and so I think in that case we would not move forward. Define it? Yeah, I know. There's a lot of nebulous words there. So I mean, I think it depends because sometimes it's hard to know how much of that is uremia. But if we think it's a primary coronary thing, and if it's EF less than 35 to 40 kind of thing, if it's less than 35, I think that's fairly advanced. Where we get in the gray zone is when how much of this is people, are they adequately dialyzed? Is that going to help it? That's where we get into trouble sometimes, but usually that's what we're thinking about. Severe comorbid disease, I'm being nebulous again here. Severe comorbid disease, so if someone has severe COPD, for example, if they're on home oxygen, that's a contraindication. If someone has psychiatric illness that is not manageable and not stable and is going to interfere with either adherence with taking medications or interfere with their ability to improve their quality of life, then that's an issue. Severe dementia, similarly, for the same reasons, is an issue. A limited life expectancy, and again, this is a bit generic, and so there's no good data to say what this cutoff should be. Most programs, and this is what we subscribe to, generally use the number of 5 years. If we think someone has a life expectancy of the next 5 years, then I think it's very reasonable to consider transplantation. I acknowledge that we're guessing on that, obviously, right? It's just a general sense of if we think someone's going to live 5 years or not. And so that's, I think, an important one. Active infectious disease is an absolute contraindication. If we can treat it and move forward, then yes, we can do that. Active or recent disseminated malignancy is obviously an absolute contraindication. A high risk of recurrent disease, and I think the most acute example of that is we've seen some patients, for example, with atypical HUS, who have up to close to an 80% risk of recurrence in selected circumstances. Those are patients where we think it's not practical to do a transplant. And that's obviously something that has to be, all of these have to be assessed on a case-by-case basis. Severely unstable social status and a high risk for non-adherence. This is a tricky one because I think there's obviously, you don't want to fault somebody for their circumstances, but at the same time, we have to make sure that people are going to be successful post-transplant. So ensuring that the supports are in place is really where I think this boils down to. And even in terms of non-adherence, I think there's a tendency, and it's very, it's very tempting, particularly when someone has had a kidney transplant before and they lost that kidney from non-adherence, to say, I'm sorry, you had your chance, you're done, we're not going to move forward again. And I think I would challenge us to actually rethink that notion, to say, well, we need to understand why they were non-adherent, and is there something that we can do to modify that? So if it's somebody who doesn't have a stable social situation or a housing situation and they're not taking their drugs, well, maybe we can help them fix that and then move forward. So I think that this is a moving target, and I think trying to move away from placing blame for some of these things is really where we need to go, and trying to figure out how to address them. But if we try all that and we see this as a major barrier to success again, then it's an important contraindication. Now, what do we normally see? This is the pathway most of us tend to see. CKD patient progresses to dialysis and progresses to transplantation. This is still by far the most common thing that we see. Now, transplantation does not last forever, and so often some of those patients will come back to dialysis and then maybe go on to another transplant. And so really, this is what we often see or we've traditionally seen, which is people may not ever make it to transplant because the dialysis period is so protracted that they don't survive the point or aren't eligible for a transplant by the time they could be. As we know, there's a 50% 5-year mortality on dialysis among all comers, and so this is a high-risk scenario. This is really where we want to see things go. CKD direct to transplant by a preemptive living donor transplant. Because we don't list patients preemptively for a deceased donor transplant, the only way to accomplish this currently is through a living donor transplant, and to do that preemptively. The challenge we have, and the reason we don't preemptively list people for a deceased donor transplant, is because we don't have enough deceased donor organs, quite frankly. So this is looking at your end-stage renal disease rate per million population over time in Canada, and these are the transplant rates. And the bottom line here is we're not keeping up with our ESRD rates, and so we're clearly are not transplanting as many people that need to be transplanted. So who gets on our list and who actually makes it to that point? Well, this is the number of patients we have on the wait list in BC. So this is at year's end. So as of December 31st of each year, where are we? So overall, there's just over 450 patients on the wait list, active or overall on the wait list in BC as of December 31st, 2015. As you see, about 250 of them are active on the list, and then there's almost just as many that are on hold for various medical issues that are being sorted out that are on the list. Now, given the data I showed you in the first few slides, we all know very well that this is a massive underrepresentation of the demand, right? There's many more people that are not active on the list or even on hold on the list because they're not close to the point of getting a transplant. So either the referrals are delayed or we're not activating them because we can't keep up with the demand of actually testing these people on a regular basis. I'll come back to that point a bit, but the main point here is that this is just the tip of the iceberg. This is the types of patients that are on our list. So this is just demographics of patients on our wait list. And so this is an age breakdown. So you do see this growth in elderly patients that are being waitlisted as candidates, which make up about 20% of our waitlisted patients now. And the other largest group, if you say just over 50, that's actually more than half, or almost 2/3 of the patients now that are on our list are over the age of 50. And then we've been pretty stable in terms of pediatric and younger age patients. In terms of gender, we're achieving gender parity, it looks like, on our wait list to some degree. That's in terms of race, this is a fairly representative distribution of ESRD rates. So in terms of access to the wait list, there doesn't appear to be a major difference in different ethnic and racial groups. In terms of blood type, again, this is fairly representative of actually what we see in our ESRD demographics. And so these groups, it's reassuring that there aren't any groups in particular that are not making it to the wait list. By diagnosis, again, glomerular disease is a big chunk. Diabetics make up a smaller proportion of patients, although they're a large portion of ESRD patients, often because they have those comorbidities that might lead to absolute contraindications that I listed earlier. This is looking at our PRA, and I'll define what PRA is in a couple slides here, but this is basically getting a sense of how sensitized somebody is. And the bottom line is the higher your PRA, the harder it is to find a match. And so these patients here that are 95 plus are the hardest to transplant group of patients. And what's happening is this group is growing over time. And it's growing over time because I think for a couple reasons. One is, as I showed earlier, we have more patients that are failing transplants and coming back to the wait list. And also because I think we have some more strategies to transplant these patients, and so these patients are getting identified more readily and quicker, I hope, so we can actually get these patients onto the list sooner. These are the deaths on our wait list, and this has been fairly steady. So generally, between 10 to 12 deaths a year among patients who are on our wait list, both active and on hold. This, again, is an underrepresentation because there are people who died before they get onto the wait list. That's not being captured here. This is a slide that's busy, but I think it's important because it gives you a bit of a snapshot of what to tell your patients in terms of what's going to happen in the next 5 years. So this is looking at if in each given year, and I'll just focus on 2001 and 2010 here. So in 2001, if someone got placed on the list for a deceased donor transplant, what happened to them in the next 5 years? Well, about 35% of them were still waiting. And then this group here in purple got a live donor transplant, about 15% of them. About another 30% or so got a deceased donor transplant, and then about 10% either were removed from the wait list or died while on the wait list. And if you fast forward up to 2010, that curve or that bar looks quite a bit better, so that now, as opposed to 35% that were still waiting after 5 years, that number is now whittled down to about 14, 13%, so that's quite a bit better. And the vast majority of patients are now getting transplanted within 5 years, 50%, over 50% with a deceased donor kidney transplant. And this is a reflection of the fact that we've had more deceased donors, so our wait times are definitely getting shorter. This is looking at it by blood type, and this just highlights how even though we're getting better overall, it's quite different by blood type. And so if you're blood type A, it's a good deal because your chance of waiting after 5 years is very low, and these are probably your very hard to match, highly sensitized patients. Whereas if you're blood type B, you've still got about 20% that are still waiting after 5 years because the wait times are longer in this group and we don't have enough blood type B donors. This is the median dialysis exposure among patients that are transplanted. So this is simply to show that our wait times are going down. So as of 2014, on average, patients were waiting about 50 months by the time they got transplanted, and that's been slowly getting better. For a live donor transplant, it's always been about 5 months of dialysis, 5 to 7 months of dialysis on average. And you know, I think that so there's two ways to look at this stat. That's great that they're only waiting 5 to 7 months on dialysis. Another way to look at it from a more critical point of view would be to say, well, geez, if they had a living donor, why didn't we do them preemptively? And so, you know, so potentially this should be even shorter than it is. This is just stats for you guys to have because patients will ask this, how long am I going to wait? So this is as of 2015, and this shows how dynamic this is because it's not quite, we have to remember to give you these stats every year so that because it does change year to year. So for a blood type A patient, the average wait right now is about 30 months, 31 months. For a blood type AB, it's quite short and often quite variable. For blood type O, we're down to about 52 months, and for blood type B, it's about 73 months. So these are the wait times. This is probably the one take-home stat you want to have for patients in terms of how long they're waiting. This is for a deceased donor transplant. So what about the transplant process and what does that entail? Well, basically there's a number of steps that have to be done. Most of you are familiar with this, but I thought it's worthwhile to just kind of lay out the steps. So there's a baseline medical workup, and the big pieces of this really are cardiac evaluation and malignancy screening. Those are the two big areas we focus on. We obviously get blood typing on patients, we get virology screening. All that stuff gets done up front. Then they see the transplant team for the assessment, and that involves your nephrologist, your surgeon, social worker, or a psychologist, and as well as the nursing staff and all the coordinators. At the end of that, we have a multidisciplinary meeting to decide on things. Immunology testing also gets done, and that ranges from HLA typing. If you have a live donor, we're doing cross matches. PRA is an important thing, and I'll tell you a bit what that is right now because that's another important education piece for your patients to understand. So the PRA is the panel reactive antibody, and simplistically, it simply refers to the percentage of donors to whom a patient would not match. So it's you're thinking a bit inverse in this. So a PRA of 95% means that patient will not match 95% of donors, or the converse of that, they'll only match 5% of donors. So that's your highly sensitized group, anyone who's 95. We have patients that have a PRA of 100%. They're really in a tough spot because statistically, they're not going to match anybody. We know that eventually they will, but the chances of them finding a match are really, really low. What makes people highly sensitized and gives them this higher PRA? Well, blood transfusions are an important cause of this. Pregnancies and prior transplants increase your PRA. So part of waitlist management is blood transfusions is something we could try to avoid. Pregnancies is not something. Whoa. Wow. I don't know what I did, but we've got mood lighting now. I feel like jazz should come on now. Whoops. Thanks, Maureen. And so it's important to understand if you have a patient who says, well, why am I not getting transplanted and the person who's dialyzing next to me got a transplant quickly, this might be the reason, is that if they've got a high PRA, it's going to take a lot longer. And then all bets really are off in terms of all those wait times I showed you. These are the baseline investigations. I'm not going to go through these in detail. Bottom line is we get baseline cardiac investigations. A lot of that is we risk stratify patients based on their age and their comorbidities to decide which investigations we want to get from a cardiac standpoint. For malignancy screening, it's generally age-appropriate guidelines for screening. And then we'll do additional checks. The skin survey is one point to remember, and a dental check is another thing to remember to do, because often that gets missed, but I think that's an important thing because the risk of skin cancer with immunosuppression is so significant that having a baseline skin survey is an important part of the assessment. The dental, just because if someone has deep abscesses or issues like that, you want to rule out occult infections, and all that stuff's probably better to do off immunosuppression if there's major dental work that needs to be done. Infectious disease screen is important. So obviously we do screening, a virology screen for Hep B, C, HIV, CMV, EBV, syphilis, and the works. All of this stuff is done initially and then again 2 weeks prior to transplant in those that have a scheduled living donor transplant. For hepatitis B and hepatitis C, most of you may appreciate the landscape has changed, particularly for Hep C. And so hepatitis B patients, if you have active disease, then obviously that's a contraindication that has to be dealt with. Often they'll need some form of antiviral therapy. Patients who are have chronic Hep B and it's been either cleared or it's quiescent and treated, they're still candidates. Hep C patients, now there's better treatments for Hep C, so I think we're probably heading toward a point where most patients will be treated prior to transplantation. For the time being, there are Hep C patients that are being listed if they're active, if they're stable, and treatment can be initiated after transplantation with some of the newer agents that are available. HIV patients, I said we are transplanting HIV patients. They must have an undetectable viral load. They must have no history of AIDS-defining illnesses and have to be very well stabilized on their heart therapy. All patients are screened for TB, and latent infection is treated before transplantation, which is obviously something that I think is happening at a lot of the dialysis units anyways, but this is still something that is important, I think, particularly in CKD where maybe we're not looking at that as closely. The transplant team assessment, I told you who the team is. Our goal, I think, and this is what I say to patients anyways, because I find when patients come to get an assessment, they feel like they're giving a test and they feel like they're going to be judged on a yes-no kind of scale. And I think it's important to right away set the stage to say our goal actually is to facilitate transplantation, we're trying to identify patients in which there is actually no benefit or we're going to do harm. And that's when we're going to say no, if that's the scenario. And so I think presenting it to patients that way, even before their assessment, is important so that they'll be quite truthful with us in their assessment. They won't put on their best suit and show up, but we want to know exactly what's happening with their health. We obviously review the risks and benefits, and we also review expectations. And so, for example, if we're talking about preemptive transplantation, I think it's important to explain to patients that you actually feel pretty well now, and that we have to time the transplant when your kidney functions at a point where you're not feeling so well, and that you'll have a dip in your quality of life after the transplant, but then that will eventually get better, and remind people that we're comparing post-transplant outcomes to dialysis in terms of quality of life. So they have to keep that perspective in mind. And then we review and identify the best options for them. And so, as you've heard through the morning and will continue through the day, living donor transplantation is by far the best option for our patients. We tell them that quite explicitly. We discuss donor outreach with them. I know that all of us are can be fairly blunt about that with patients, and I'll challenge patients if they say, I don't want to think about living donors. We'll engage in that kind of a conversation respectfully to say, well, why not, and what are the issues? And as Sharon said, this is not a one-time conversation. This is a longitudinal conversation, try to get people to buy into this, and so I think that's something that's really important to get into KCC clinics. We also, in many patients, and in patients where we think this is an issue, talk to them about dangerous practices such as transplant tourism, traveling to another country to buy a kidney, tell them not to do that explicitly, why they shouldn't do that from an ethical standpoint, but also more importantly from a outcome standpoint, it's a problem for them. So we go through all that in a fair bit of detail during our assessment with them. At the end of all that, we then have a multidisciplinary team rounds, and most of you haven't had the opportunity to see what happens in there, but I think it's a really critical piece of what we do, and probably the most critical piece of what we do. Never is a decision about transplant candidacy made by a single individual. It's a team effort, it's a team assessment, and the decision is made where every member has their say, and everyone reviews their findings, and then we discuss it as a team. It's charted for transparency, so it's not in a hidden room somewhere. Everything's out there and open. And then a follow-up plan is developed at that meeting so that we have a tangible place to go moving forward. Now, the wait for a transplant, I think once we've decided, really, if someone has a directed live donor transplant, as soon as the donor is ready and approved and the recipient is ready and approved, and assuming the recipient's ready to receive a transplant medically, we'll just book it, and the booking times vary, but usually we can get it done in a matter of a couple months, in a very short time period. With kidney pair donation, that timeline is challenging because we can approve them for kidney pair donation, but then you're waiting. There's 3 match runs a year, and then you got to wait to find a match, and so that time is a bit unpredictable. Activation to the wait list, really, for patients who don't have live donors, they get activated to the list, or patients who are in KPD can also be activated to the wait list, and we'll typically do that as well. Now, I want to just take a moment in the last couple minutes here to just remind everybody what our allocation looks like. So when you're on the wait list, generally, the major factor is wait time on dialysis. So irrespective of when they're assessed and irrespective of when a patient is activated onto the wait list, their place on the list is determined by how long they've been on dialysis. Everyone gets backdated to their first dialysis date. And that's really the primary determinant of how quickly where you're gonna be on the list. There are patients that get priorities. So pediatric patients get a priority and go to the top of the list. Highly sensitized patients that I talked about, these patients that can match less than 5% of potential donors, they go to the top of the list, rightfully so, because they have such a hard shot at getting one that we can't, on top of that, have them wait because of their dialysis time. Anyone who's a medically urgent patient, so an example is someone who's on dialysis and they're running out of vascular access. That patient's medically urgent, they get a priority. I didn't put combined transplants, but someone who's getting a heart, liver, or a heart, lung, or something, or a kidney, liver, I should say. I'm sure they get prioritized too, but if we do a kidney, liver, they'll get priority because that patient obviously is very unwell. And then other exceptional circumstances, for example, prior living kidney donors, if they go on to develop end-stage renal disease, they will get priority, assuming they're acceptable transplant candidates. The other thing that's important to remember about allocation is that we do age match. So, this is consistent with what's being done nationally, in that younger deceased donors are generally allocated to younger recipients, older deceased donors to older recipients, and then middle-aged is kind of all comers, first come, first served. And so when we're talking to our older recipient, for example, one of the things we do tell them is that, well, you're likely to get an older deceased donor. So the benefit of a live donor is that much more amplified. And so that's why another way that we push living donation in these patients. Lastly, just when should a patient be referred? Now, I think this is actually, before I do that, just look at the timing of referral in BC. And so this is looking at different centers referring centers across the province. And this is looking at what time after dialysis or relative to their dialysis timing were they referred for a transplant. And on average, although there's some variability here, about 80% of patients are referred within 1 year of starting dialysis, which is actually fairly reasonable. But there are patients, and there is variability in different regions depending on, patients waiting 1 to 3 years or more than 3 years before they're getting waitlisted. Now, it's hard to look at a stat like this and say what's right and what's wrong, because I think ideally we would say, sure, everyone should be referred early before they approach end-stage renal disease. But this is not always feasible for a number of reasons. A, the patient may not be ready. B, even from a workload standpoint, the reality is that if we work up everybody at a very early stage, we don't simply have the manpower to work them up from a medical standpoint, from an immunology standpoint, to get everybody worked up right off the get-go. So there is some element of prioritization that ends up happening, or triaging in terms of referrals. So what do we consider? Wait times based on the medical urgency, blood type, and living donor potential. So a very pragmatic approach that we do, I think, use is we prioritize patients, A, that have an identified living donor. So if you have a donor, we see them right away, preemptively. The goal is to do a preemptive transplant. Patients who may be highly sensitized, if we know someone's had multiple pregnancies or they've had blood transfusions or a prior transplant, we know they might be in that 95% plus PRA group, in which case the wait times are relevant. They should be seen early so we can get them on the list faster. And then third, I kind of made this up, but basically it's an anticipated wait time of about 2 years is generally what, 2 years is a made up number, but I think the idea is that if someone's 8 years away from getting a transplant once they get activated, it's probably not the most efficient thing from a workup standpoint to work them up right away. As I said, ideally, we should work them up right away, but it does become a very pragmatic approach from a manpower issue. But I think if we prioritize patients that have living donors, that all works. There's a huge but, and I've bolded that because I think this really is the bottom line here. This approach, prioritizing patients like this way, it mandates that the education and the support that patients have to talk to them about their options for transplantation, to make sure that they've done everything they can to find potential living donors, has to be done uniformly. So right now we're doing it at the transplant centers. A lot of you are doing it at your centers, but I think a major issue we have to do is this has to be standardized and it has to be across the board so that patients aren't being disadvantaged because they're not coming down for an early assessment for transplantation. And that's the piece I think that what a lot of the speakers today are speaking about, and that's kind of, I think, the main point I wanted to end with there. So in summary, benefits of transplantation do apply actually to most end-stage renal disease patients. And so clearly we're not transplanting everybody we can be. There are not enough donors to meet the demand. Wait times are certainly shortening, but it's important to remember they still vary by blood type. The goal of our assessment is to facilitate the best post-transplant outcome possible for the given patient, and if that means that they shouldn't get transplanted, that's what we do. And then prioritize referral is practical, but mandates a high level of education of all CKD and ESRD patients. So I'll end there for questions. Sorry, I went 2 minutes over. Questions? It's percolating. Okay, we'll end there. Oh, Mike's got a question.
So I've always wondered this. What happens to the patient who goes on to dialysis, recovers kidney function, and then needs a transplant again in terms of their wait time?
Their start date?
Yeah.
Yeah, that's a tough one. I mean, those are case by case. Typically, it depends, right? So if someone's, again, I think it depends on how long. So if someone's on dialysis for 4 years and then they're off for a couple months, I mean, I think it would be a disservice to do that. But if someone's transiently on for a month or two and then they're recover and they're off dialysis for another 6 months, then you probably go from their date of chronic dialysis as opposed to the AKI episode.
What is your message to the obese versus anyone who's not controlling?
The message is that we go through the outcomes, and so the first issue is transplantation feasible? So there is a cut point where technically and surgically it's not feasible, and at which point we'll say, yeah, there has to be a mechanism of weight loss. Irrespective of that, even if it is technically feasible, the advice is that your metabolic outcomes and your post-transplant outcomes will be worse because you're obese, and there has to be a strategy to try to lose weight. The practical side of that is that we don't have an effector arm for that advice. So we don't have an exercise rehab program to say that if you're on the wait list, we're going to help facilitate that. So patients who have end-stage renal disease on dialysis aren't the most mobile. And so the challenge we've had is actually trying to facilitate that. There is a subset of patients that are morbidly obese, and particularly when it's a technical challenge, where we've talked about bariatric surgery and referred them for that option. In Quebec, for example, they're doing a fair bit of that, so I think that is another option that exists. Okay. Thank you.